Good afternoon. Welcome to Not All SG&A Cuts Have to Cause Pain. I'm going to give people a minute or so to jump on, so hang tight with me, please. Okay, good afternoon. My name is Paul Siegert. I am the managing partner for PCS Advisors, and today we'll be talking about SG&A cuts. Not all SG&A cuts have to cause pain. That's the title of our webinar. I was on a call with a colleague a short time back, and he drew my attention to a survey that we'll talk about a little bit later in the presentation. And it was the seed that got planted in our minds, and we decided to host this webinar. A little bit about me, share a few things with you. One, some of you that are attending today, I've already had the chance to work with, and you know me. Others don't. And if you know me, you know I usually have more hair than this. So not only is it true that 62% of CFOs will be making SG&A cuts because of COVID-19, I had to cut my own hair because of COVID-19. So when we get a chance to meet, if we do, and I hope to meet as many of you as I can, I will likely have more hair. The second thing I'd like to share with you is that I have 5 kids. That occupies most of my time when I'm not talking to companies about healthcare. And the third thing I'd like to share with you is the fact that my first career, I was a Russian intelligence analyst for the US government. I was in the military and I was attached to the NSA as a Russian intelligence analyst, and I speak, read, and write Russian. And I share that with you so you know that I am qualified as a nerd, and this can be kind of a nerdy topic. So let's jump right into it. I want to respect your time. My goal today is to get the point across in about 20 minutes and do a series of webinars that break each of these topic areas down that we'll get a high-level overview of today. So let's get into it. Just a minute. There we go. First off, why are we having the webinar today? According to the IMF, the world economy will experience the worst recession since the Great Depression. I'm an optimist by nature. I'm an entrepreneur. Lots of us on the webinar today are as well, I'm sure. And so I'm hopeful that this will be, this is an exaggeration, but no doubt we are headed into some tougher times than we're leaving. And according to Gartner, 62% of CFOs will make cuts to their SG&A due to COVID-19 related disruptions. Here's an overview of what we'll review today, or the topic and the content of the day. 70% of California employers buy healthcare retail. We're unique in the country in that way, and it's really surprising to me. It was surprising to learn that we are the last state, really, where the majority of employers purchase their healthcare retail. In the rest of the country, more than 60% of employers have a custom health plan or some sort of an alternatively funded health plan. Yet in California, we have 70% of employers that are still buying healthcare retail. And the result of that is that we are paying more than the rest of the country. We're paying 26% more in premiums. And when you think about the fact that we have the largest risk pool of any state, and we're the home to innovation for the world, really, it's pretty crazy that we're paying so much more than the rest of the country for healthcare. And I believe there's a connection between the fact that we still predominantly buy healthcare retail and the fact that we pay more. There is good news today. You can manage the cost drivers of healthcare. And it's a great topic at any time, especially now when CFOs are reporting that they will be looking for ways to cut their SG&A. The average employer spends $15,000 per year per employee on healthcare, and that's up 30% in just the last 5 years. Every year, SHRM, the Society for Human Resource Management, puts out a study of these numbers, and it's been consistent the way that it's been trending. And I know I don't need to tell our audience that today, but just to reinforce it. And the current model isn't working. I hear from CFOs on a daily basis and benefit managers that the model that they're subject to today in the retail healthcare market is not working for them. Why is that? The first significant problem that I see is that all players have misaligned interests. Everybody in the supply chain of healthcare, all of the vendors, traditional brokers, health insurers, and all the vendors in between that make up the plan that your employees use have misaligned interests. When costs go up, they make more money. So uh, needless to say, you're on the other side of the fence as an employer alone. And that doesn't have to be that way. When you have a custom plan, you can align everyone's interests. The next problem is that there's no management of the frequency and severity of claims, which is where most of the dollars of every health plan fall. The larger the plan, the smaller the percentage of dollars that are spent on administration. When you get to a really large plan, it's well below 10%. And on a very small plan, maybe it's 20%. But for most of the folks attending today, it's 10% or less of the dollars that are flowing through your healthcare plan that are assigned to administration. The rest of the dollars, whether they're in pooling charges or reinsurance or claims, they all end up turning into a claim dollar at some point in the process. And it's pretty crazy to me that most conversations are not about the big dollars in healthcare, the claims. And you can manage that frequency and severity of claims, and we're going to talk about that today. And the third problem that I'd like to address is the fact that we have HMOs. They're a unique animal. They're not in every state in the nation, and they do tend traditionally to trail PPOs in their pricing by 1 to 2 years on the trend. So perhaps you're getting at a 10% lesser price by moving some of your population to an HMO or making an HMO option available. And lots of employers, not knowing that there are other options out there, feel they've done everything they can do by simply transitioning from a PPO to an HMO. But once you've bought that 2 years of time in your trend, you're back right where you were before, subject to all the limitations of a retail plan, and you're subject to the trend increases that are going to hit you on an annual basis. So the unsustainable model currently that most employers, 70% of California employers are subject to, has unpredictable increases, skyrocketing costs, $15,000 per employee per year, no transparency, and no control. The solution, a custom plan, will allow you to get transparency, gain control, and limit costs. Custom health plans is what we call, what we do. We build plans for employers as consultants. They allow you to do these things. First, convert OpEx to EBITDA. Take one of your largest operating expenses that most employers report is in the top 5 and in many cases top 3. You can take a significant portion of that operating expense and convert it to EBITDA for your company by putting in a custom health plan. The next thing that you'll gain by transitioning from retail to the custom health plan world is predictability. Rather than waiting until the end of a plan year to find out how the plan year went and what kind of an increase you're going to face, when you have access to real-time claims data, monthly, quarterly, and so on, you know what's going on, not what went on with your plan. And rather than looking in the rearview mirror to manage this situation, you're able to look through the front windshield. The third thing that you'll get from transitioning to a custom health plan is better outcomes. Believe it or not, in healthcare, the very best providers who get the very best health outcomes cost less. Who would have thought? With a custom health plan, you can steer your employees to the very best providers, get them the better health outcomes that you would like for them to have, that they deserve to have, and lower your costs at the same time. You also decrease your risk. And lastly, you have aligned incentives. Everyone that's involved in delivering healthcare to your employees will have an incentive to control costs and improve outcomes. What are the 4 main cost drivers of healthcare? According to Milliman, prescription drugs currently make up 27% of a typical health plan. And we'll talk a little bit today about how to manage that expense, manage that supply chain. Hospital or facility charges make up 30% of the cost of a typical health plan. We'll talk today about how to limit the fraud, waste, and abuse that occurs in that space. Outpatient surgeries make up 20% of the costs of a typical health plan, and primary care makes up 20%. We'll do future webinars that address each of these areas in a deep dive. Today, we're going to talk about the first three in the interest of time. And I think we'll do a good job of giving you an idea of what's possible when it comes to managing the supply chain of healthcare. First, we'll talk about prescription drugs. There are three large pharmacy benefit managers that control 76% of the drug market and of the drugs that flow through health plans to your employees. And those three large PBMs have 32 different ways that they can hide revenue that I think is unethical because it's hidden. So in addition to charging a per script fee for dispensing a drug, they have all of these 32 other ways that they can layer cost into your plan, and it's significant in how much cost it adds. If you make the simple change, when we build a custom health plan, we select a pharmacy benefit manager that we consider fiduciary to your plan. And they only make their revenue, it's all transparent, and they only make their revenue on a per script fee basis. They have no other way to create revenue, and so they have no incentives to drive cost up in your plan. Here are a couple of examples where we made this adjustment. The first is a municipality with 2,309 covered lives, and in the first year, they saw a 34% cost reduction in their prescription drug costs in their plan. The second is a food company with 419 covered lives, and in the very first year, they saw a 52% cost reduction in the prescriptions that flowed through their health plan. So when you think back to the Milliman slide and you consider that drugs make up about 30% of a plan's cost, 27 to be precise, and in the first example, we reduced the drug spend by 34%, give or take, we reduced their overall healthcare costs by 10%. And 15% overall healthcare cost reduction for the food company, a massive impact. And drugs they're becoming a larger percentage of a health plan every year. It's expected in the next couple of years that they'll go from 27% to as high as 50% of your plan costs. So that's why we're talking about it first today. It's something that we have to get control of, and we can. It's being done all around the country every day, in ways that have been perfected by the very largest employers in the country who are the very best at managing supply chains. The next area is hospitals, facilities. I want to draw your attention to, this is all public data. You can go out on the internet and pull these reports on any hospital. And on the left column, you have actual costs. For our example here, we pulled a Bay Area hospital. We have actual costs in that left column, 750 million and change. And then you go to the middle column and their charges, which equated to almost $11.5 billion. What I want to draw your attention to, of course, is in yellow, the cost to charge ratio. 6% of their costs represent what they charge. And certainly they don't get all charged dollars in-house, but they get a lot of them in-house. And we can manage that supply chain a lot better than simply relying on a PPO contract to get us a discount. Let's look at how we do that. Here's an example of a CT scan. These numbers would be fairly consistent around California. You have a billed amount of $2,400, and you get an EOB in the mail and you see what your PPO discount did for you. And in this case, after discount, the plan paid $1,856. And when you go to the bottom and you see that green $250 number, that's the actual cost. In fact, there was a recent article in the LA Times that showed that the cash price for one of these procedures to be done at a facility in Los Alamitos was $287 for the cash price. If you walked in, said you did not have insurance, and you wanted to get a scan, they would charge you $287. Yet if you had insurance, they would bill your plan $1,856 or whatever the contracted amount was for your insurer. We believe that cost plus a reasonable profit would make more sense, as do many of the very largest employers. And our clients, the employees, can go get scans like this done at well below $1,000, and they do it every day. The next area we'll talk about is outpatient surgeries. What I'll show you here is major carrier A in one column, major carrier B in another column. These are household names, these carriers. out of kindness, I'm not putting them on the slide. And you can see that the total cost at the bottom is about $500,000. We pulled some pretty common diagnosis codes for procedures and got the contracted price and totaled those columns for you. 555,000, 515,000. Now, when you negotiate better pricing, you manage the supply chain like you do for all other areas of your business. We were able to get the very same procedures for $184,000 and better outcomes. As I mentioned earlier, the very best providers, the best surgeons charge less and have lower reinfection rates, lower admittance rates to hospitals as a result of their procedures, et cetera. Here's what a customer has to say about moving from the retail healthcare space to the custom healthcare space. And here is a case study of an actual employer in the Bay Area and what their 5-year trend line is looking like today after making a transition from a retail plan to a custom plan. They realized immediate savings, and then over a 5-year run, they're on track to see about $12 million that will go back into their company. And their plan is better than the plan that they had. When you move to a custom health plan and you start to create incentives for your employees to become great consumers of healthcare, you can reward them when they choose to go to the very best provider. You can reward them knowing that you are seeing lower cost to your plan. You can reward them by waiving their out-of-pocket costs. And the plan's costs go down and the members' costs go down. It's a beautiful thing. And it's happening all over the country every day. And it's not just the very large employers that are doing it. Throughout the rest of the country, this is very active down to groups below 100 employees. And it can be done here as well. So what is the next step in the process with us? If this looks like something that you would like to learn more about, we do initial cost modeling. And with everything that's going on in the world today, we've made the decision to make cost modeling available at no cost. What do we need to do cost modeling? We need some limited information from you, stuff that your HR department should have at their fingertips, a basic census. So, who works at your company, current plans. We want to make sure that any modeling that we are doing does not downgrade the coverage that you're providing your employees. So we need to know what that coverage looks like, your current enrollment, who's on what plan, and your last renewal. With that basic information, we can give you a pretty darn good estimate of costs and a 5-year outlook of how your plan could perform. It won't be to the penny accurate, but it'll be pretty darn accurate. Okay. Before we close, I'd like to address the 3 main reasons that CFOs share with us for not moving to the next step with us or not exploring this further. Number 1, plan your flexibility. I just renewed. I don't renew until January. I'm not at my renewal. You have plan your flexibility. And certainly in these times, it very well may make sense to look at a plan year change. If you're in the retail market, your health insurer has to guarantee your rates for a year. You do not have to guarantee that you'll stay. You can leave the first of any month. And we're happy to explore that option with you. In fact, we might be putting the cart before the horse anyway. Let's first quantify the opportunity to see if it's even a consideration. The second is we like our broker. We're not here to get them fired. We operate as consultants. We do operate as the service broker for some of our customers, but we start every relationship as a consultant. When we begin to work with a new prospective client or a new client, we do not ask for that broker of record letter immediately. You can engage us and keep the people that you love that you've been working with. Last, we don't have the bandwidth to pull all the data together to give this the time that it needs and truly evaluate this opportunity. The slide prior listed the things that we need. And after the webinar today, we'll make sure to get you a copy of the webinar recorded and some other resources and a list of the things that we would need in an email form so you can see what it would take to put cost modeling together for you. But suffice it to say, your HR department has these things at their fingertips, and it's pretty simple to put together. In closing, more than 60% of US employees are covered by a custom health plan. These concepts oftentimes seem new, especially in our market, where they have not been adopted as much as they have in the rest of the country, but they're not new. Over 100 million Americans are covered by a custom health plan. 60% of US employees are on a custom health plan, so more than half. 62% of CFOs do report that they will make SG&A cuts due to COVID-19 disruptions. Healthcare is a huge opportunity and is one of the few, if not the only area where a CFO will be able to both reduce costs and bring good news to the employees. Some cuts will cause pain. This one does not have to. And it's a great opportunity at any time, especially now. Retail plans will see larger increases in 2021. We're hearing from underwriters today at the large HMOs and PPO carriers in California that all the gearing up for COVID-19 that was required by hospitals will be priced in to the 2021 renewals. So in addition to what normal healthcare inflation is, there'll be an added surcharge essentially for COVID-19. In addition to that, there's a new rule that you have to have your renewal in your hands as an employer 120 days prior to your renewal date. And while that will have some benefits potentially, the downside is underwriters will have less information to work with. And when that happens, when there's uncertainty, they price it in. That too will add cost to the 2021 retail plan renewals, which makes it an even better time to consider a custom health plan. And initial cost modeling is the next step. We've discussed that. Thank you for your time. I sure am glad that you joined us today. I look forward to interacting with many of you in person, hopefully someday, and by web meeting until we can. We'll follow up with you as I mentioned. You'll get a copy of this webinar as well as a list of the things that we would need, and we'll reach out to see if there's any way that we can help you and your company navigate these unprecedented times. Have a great day.